I think being a patient has a lot to do with how I am as a psychiatrist. I would, I might not have even said that a few years ago, but I think it is, and there's no doubt really in my mind. But then, if none of this had happened, and I'd managed to train as a psychiatrist from medical school and done well and everything, and it would have, I would have been a different psychiatrist, and I'd have probably had different life experiences.
This is a Thinking Mind podcast.
Today we have with us Dr. Rebecca Lawrence. Rebecca is a consultant psychiatrist specialising in addictions and chronic pain. Rebecca also has a diagnosis of bipolar affective disorder, which has previously required her to be treated on a mental health ward and undergo ECT, electro-convulsive therapy, as well as taking multiple medications, including lithium. Rebecca has spoken openly about her experience as both a doctor and a patient. She's written a number of articles for The Guardian and has her own blog, Doctor and Patient. Thank you for joining me today, Rebecca.
Thanks very much.
I wanted to start by asking you about how you ended up as a psychiatrist, because I know how much of an interesting story and journey that is.
I think, I was always interested in psychiatry from when I was a medical student, and I can't say there was a particular thing that led me to be interested in it. I just found it interesting, and when we had lectures on that, it was more interesting than the kind of more general medical things. So I did my psychiatry attachment, and unfortunately that didn't go particularly well. I didn't actually pass the attachment. I passed the second one, which is more hard to admit to than any mental illness in many ways, looking back. But I decided at that point that I wouldn't go straight into psychiatry, and that I would do general practice training, which you could do then just by, sort of doing a job at a time. You could make your own scheme in the way that you can't now. So I did a few jobs in Scotland, and then I went down to Cornwall to do my GP year, which I just thought would be a lovely change. It would be, by the sea. It was beautiful. It was a beautiful place. And I was, it was all going very well. But halfway through the year, I got married, and almost straight after that, I found I was pregnant, which was a happy thing, but just I hadn't expected it to happen that quickly, and I was anxious about it at the time. But I think what happened then was that I just became unwell, really, and it's very difficult looking back to quite describe, what that was like, because I think, you have this idea of what, an illness is like, of what being depressed, of what having psychotic thoughts is like. But I think of necessity, it's very much sort of separated from yourself. You see it in other people, you read about it, and you could almost imagine it happening to you, but it would still be separated from you. So when I was depressed, I couldn't really see it. I didn't see that I was depressed in mood. I didn't see that the things I was thinking about were, well, maybe unreasonable. And I think that is something which for me has probably persisted throughout. I mean, I do have much better understanding and insight now, but I've always found it very, very difficult to equate what I feel with what, someone would say was wrong. But anyway, at that time, I ended up very briefly in hospital down there, but kind of was looked after by my husband and one of the GPs who was very, very kind to me. There was definitely a kind of, let's not make too much of this, let's not have too much in the notes, that could damage your career thing going on. And of course, if people are saying that, then you think, I hadn't necessarily thought anything like this would happen. But if someone suggests that it might be a problem, then you think, well, my goodness, this is going to be a problem if if this is found out by people. But what happened was that I ended up coming back up to Scotland, back to Edinburgh, where I trained and lived before that. And I saw my GP. She sent me to the psychiatrist, and I ended up in hospital straight away. And that was, again, I was kind of thinking, this isn't why they admit people to psychiatric hospitals. This isn't what I thought at all. It wasn't what I was expecting. And, if someone asked me, what was I expecting? I don't know. It just wasn't the kind of thing you think will happen to you. So I was there, and I actually had a very, I would say, difficult time over the next couple of years in that I was in and out of hospital. I didn't cooperate very well with taking my medication. I had several courses of ECT, and more than I'd realised actually when I looked back. And I did do well when I had that, but then I didn't really want to carry on taking the medication afterwards because I didn't think there was anything the matter with me. So that was problematic. And I also had my baby during all of that. There wasn't a mother and baby unit, so kind of ended up in a horrible general ward with her. It was actually the ward where I'd failed my student attachment to kind of rub salt in the wound. But it was a very, very difficult time. And I think during that, I kind of gave up hope on my career, probably on myself, really, that I would not be able to work as a doctor again. And like so many of us who are doctors, you know, that's a big part of what you are. And I just wasn't sure what I could be without it. So, you know, I remember my psychiatrist saying that he thought I had a 50-50 chance of getting back to work, which I think at that stage makes you think zero, even though there's still the 50 side of it. But eventually I did get a bit better. And I suppose that was the point. I just thought I would try and get back to work. That was very difficult, but I did get back. I did a 6-month SHO post in geriatrics, I think it was at the time, which I found very difficult. And then 6 months finishing off my GP training. And then I thought, no one's going to employ me as a GP. Let's do psychiatry after all. And that, I think, probably was one of the biggest and, in a sense, most daring decisions I've probably ever made, because no one thought it was a good idea apart from
Good
me.
for you.
That's fair to say. So that was kind of how I got there.
Yeah, thank you for that. Thank you for being so honest. You mentioned that at the time when you were undergoing your first illness, they didn't write in the notes exactly what was happening, and you were told to kind of brush it under the carpet, so to speak. Do you think that's something that would still happen today if someone was in your position?
I think it's much less likely. I think there's various initiatives as well, like the practitioner health programme down south, and in Scotland we're hopefully getting something, and we've got them at the moment, in fact. So I think there are other options where I think the situation I was in, if I look back, I don't even think I was registered with a GP, whereas now, even in your appraisal and stuff, you know, I still had my GP in Edinburgh, not much use. Whereas now I think things like, you know, when you go through your appraisal each year, you have to kind of confirm that you have. And I think there is a lot more thought as to, you know, what trainees are doing. I think then there was more in the way of, you know, can you just see this person, or, you know, just not exactly corridor consultations, but just being a little bit. And I think it was done in a way that was meant to be helpful and kind. You know, it was not it was to try and make sure people were protected. And I think possibly there was more stigma. I think it's changed. Really, it's just different then. But it was a difficult. I think it's a difficult situation, but I think probably it wouldn't happen like that now, I like to think.
Yeah, me too. I agree. I do think it has changed.
When I got back to Scotland, my GP being still there, I saw my GP and everything else was recorded. I think they had a different situation then in psychiatry, certainly in Edinburgh, whereby people had sort of separate notes. Everyone's notes were separate from the physical notes then, which they're not now. But I think if you were a healthcare professional, your notes were also kept in a special cupboard, which it may be not seen as ideal now, but they were doing what they felt was the right thing then, and I think it was probably quite common practice. You know, I think the more you make things and it's slightly hidden, the more you stigmatise, you create the kind of fertile breeding ground for sort of stigmatising things. So, although I often, people will say, you know, would you prefer to be treated in area or out of area is one question that can come up. And personally, I would say in area every time. I've actually experienced both. But I think in area, not only because your family are closer on the whole, but also because you're not being sent away. There is something difficult about that. It's difficult with psychiatry because it is about your symptoms are expressed very personally. And I think that can be quite quite difficult compared with, maybe how you talk about your chest pain. I think there'll be different problems with that as well. But I do think it needs to be, if not normalized, at least not hidden away. Real problem, that, I think.
I read in one of your articles that you wrote that trainees and training doctors and trainees are less likely to disclose their diagnosis. Why do you think that is, coming as you're a psychiatrist? What changes, do you think?
Well, I think it's, I think if I'd been in a situation, I suppose I became kind of quite acutely unwell. And I think because I was pregnant, it was a little bit more dramatic. And I think in a sense, because of that, I didn't get the chance not to disclose, in a sense. But if I was in a situation where, and I've been, talked to trainees who've been in these kind of situations where, I was feeling depressed, but I was worried people would think I couldn't cope, that, maybe I wasn't very, up to it, that kind of thing. I think there's a lot of comments that are made casually about situations that we don't always think what we're saying. And I mean, I would include myself in that as much as anyone else. That can make, or the way sometimes staff, and again, all of us, can kind of refer even to patients without thinking, just talking about things that could make you think, well, maybe I'm that person. If they knew that about me, then maybe they'd say that about me. And it's very difficult to get right. I mean, we can't be, actually, in a sense, tiptoeing around the whole time and around everything would be impossible for us all to do. But I think I think psychiatry is particularly difficult. I think there is an ongoing, I think maybe as doctors we're hard on ourselves as well, doctors and nurses, other health professionals. But I think there is this thing of, is it mental illness? Is it just weakness? Am I just being a bit pathetic? And I think quite often people are quite critical of themselves. I'd say I don't. There's a lot talked about self-stigmatization, and I think yeah, we do that. But I think it comes from what we see and hear, even as medical students. I think it comes from very early on how we see people talking about patients, and some people will say that psychiatrists are particularly stigmatizing. I don't know whether that's true or not, but I think I've heard many health professions, in acute, in psychiatry, across all the different professions. And some people, I think, maybe don't understand psychiatry or are afraid of it. They find it difficult, and some people do say things that are difficult, and many people fortunately don't. But I think particularly when someone is struggling, they pick up the difficult stuff. And I think, people are very, frightened of what could potentially happen to them. From my perspective, I felt like I can only describe it. I felt sort of second rate when I was a psychiatry trainee, the kind of core trainee equivalent that I was then. And I think it was, I mean, totally foolishly, because, plenty of people have plenty of problems. And I discovered some of that later. But at the time, I thought, gosh, I'm the one who's the kind of inpatient, the kind of bit of a disaster. Everyone thinks is a bit pathetic and can't work certain places. Whereas, I don't think people were thinking that, but you do sort of take that view of yourself as not being as good. I think that's quite common.
And I also feel like at work, for me, throughout my career, the assumption is that you don't have a mental health condition, but 1 in 4 people do have a mental health condition at any one point.
Yeah.
So although in supervision and things like that, we get asked, how are you doing? I do feel like generally at work, people just make that assumption still in this day and age, despite the reduced stigma that we've had over time. I remember you saying, I read that you were treated and then worked on the same ward, and someone recognised you. Is that true?
Yeah, I didn't actually work on that ward. I mean, the thing with the wards is they've actually changed their function over the years. So it was a situation though where I was working on a different ward, but went to visit this person who was, I think, boarding maybe there, and it was another patient who who recognised me and sort of shouted that how can you be, a patient and then be the doctor kind of thing, which was I don't know. It's actually it's stuck in my mind actually that happening, because I suppose I thought, well, yes, this is not actually a bad question. It's it wasn't asked maliciously. It wasn't said nastily. At the time, I felt a little bit embarrassed because I had someone else with me. But it's just sort of stuck in my head. Why was it? Why was I the patient and then became a doctor? And I think a lot in the last few years I've thought, essentially I have been both, and that's kind of relevant. But it was, I suppose, it was uncomfortable at the time. I was, there's been in recent years that there did seem to be a possibility that the ward I work on now might actually move venue to the one where I'd been an inpatient, and I was very glad when that fell through, I have to say. And it would have been okay. I would have got used to it, because in a sense, I work at the same hospital. I've seen a lot of the same people. You get used to things, and I think by not avoiding is, for me, has been the most important thing. But I just didn't really want to do that, And I say I would have done it, but very glad that it didn't happen.
Yeah, I think that's fair enough. Have you ever been treated by someone that you've worked with professionally?
Yes, actually. One time when I was sent out of area, I didn't work with them, like on a day-to-day basis, but it was someone I'd been a consultant with, and he was my consultant when I was in this ward. That was after I'd become a consultant, and it was out of area from Edinburgh, and he was very lovely and kind and very consistent, I think, actually, very professional about it. I don't think it was ideal, but I remember vaguely that when I was offered the choice, the other place would have been someone I knew even better. So I think I thought, well, and I suppose that's partly why, for me, the whole in area, out of area, I hope never to be in that position, but I would rather be admitted locally than, out of area.
Do you think at all you've been treated differently because your consultant may have known that you were a doctor? I know initially you were a GP trainee, but even then.
Yes. Yeah. I think it's difficult to say right back at the beginning. I can't remember any kind of nuances or anything that would have been particular then. I think, if anything, I probably made things a bit more difficult for myself by asking, sort of more detail or more questions that maybe other people wouldn't have done. I think it did become a bit different, because and during that point I wasn't working as well, so I was just a kind of person who wasn't working really. And then when I got back to work, I think it was different when I started doing psychiatry, and I have been quite lucky in many ways that I've had continuity of my treating consultants. I've probably had, I think it's 2 main ones over the years, and I've known both of them from my first admission in Edinburgh. So I think it's been odd in a way, because it's been slightly separate from what other people would get in the kind of community mental health team. I've never had like a CPN, or I've sometimes felt I would have liked less consultant support, if you know what I mean. But having said that, I think having continuity in someone who knows you is something that doesn't always happen now. And, that's more like how people perhaps used to practice previously. But I have had that, and I'm absolutely sure that's because I'm a consultant psychiatrist. And I think that's been very helpful for me. I see my psychiatrist still, regularly, but I also know that I can just email him if I need to. And that does make things a lot, it takes the kind of whole pressure off. And I'm very aware that for a lot of people, they are discharged back to, GP, whatever. And it can be very, very hard to get further sort of secondary care input. And even if you do, you might meet someone who didn't know you at all, so you have to start again. I think that I would say that although there is the slight thing of being slightly a special patient, because it's almost inevitable if you're a kind of colleague as well. But I think the big advantage has been the continuity.
Yeah. You mentioned that you have been given the diagnosis of bipolar, but you yourself are not entirely sure exactly what your mental health diagnosis is. For the people listening, would you be able to explain exactly what you understand bipolar is? Because I feel like a lot of people might just think you're just really happy one day and you're really sad the next. But from my professional experience, it's quite different. How would you explain it?
Well, I think if I was explaining it as to what I have, I mean, I've had some largely depressive episodes. And at first I was diagnosed with psychotic depression. And it's been, I think, the bipolar was kind of mooted around for quite a while, but it's probably been more of a firmer diagnosis in recent years. And I suppose I would say, I mean, I still have my automatic responses. I probably don't have this, but I would say yes. I mean, I do get discrete kind of episodes, and when I'm depressed, I think I get extremely low and pretty hopeless, and get pretty stupid ideas about what's happening, and that can become, it's very difficult to do anything, to get up or even eat or sleep or wash or dress, that kind of thing. And when I look back then, I mean, I had episodes, I think, I mean, I'm never quite sure about the term, but it might not be unfair to say they were more kind of mixed episodes. I mean, I was very agitated, very sort of, couldn't keep still, couldn't stop thinking, that kind of thing. But I think, I've had other periods where I have been, I don't know, I mean, people talk about elation and being very happy. I wouldn't describe what happens to me as being very happy. I do think I get quite speeded up at times, and I get very, very irritable, and I can see that coming as a, thing. And quite often that will build up and up and up, and quite frequently be followed by a kind of crash down in mood. So I don't think any of it's particularly enjoyable, in that, I wouldn't, I wouldn't, call it, like periods of being really happy and periods of being really sad. It's just all pretty bad. It's difficult. I mean, I think our diagnoses in psychiatry, as we all know, are very much, they're categories. You can fulfill these three symptoms, and that makes you something. I don't think things are ever quite as clear as that. But I did make, I suppose, particularly when I started writing about it, I thought I have to kind of stop saying I haven't got any diagnosis, and at least try and accept what's being, said. And I think I am more accepting that it's something that could be the problem. I think the problem I did have earlier on, and which I think I have written about, was that I felt very, and still when I'm unwell, felt very sure that everyone thought I had a personality disorder, which I think is stigmatizing of me, thinking that, because it's a horrible diagnosis for people to be given. It's one of those diagnoses I don't think any of us know quite what to do with, because it can be useful at times. Very controversial, and I haven't sorted out my thinking about it. I think what I'd observed perhaps in my early years as a student and a junior doctor was a fair bit of criticism of people with personality disorders. And I think it is probably also fair to say that I have, over the years, heard people, maybe particularly talk about health professionals with mental health problems as often having behavioral or mental or personality problems. And while I do step back and think, well, actually, I don't really fulfill the criteria for this, it's something that I think gets to me at times, usually when I'm unwell. And I think it was something over the years I found very I felt that it was likely that people might say that about me or think it about me, and I found that really difficult. And I find it difficult when I hear people saying it about people. I think we all hear it, and it's not because I'm saying that it's a wrong diagnosis. Even it's not. I'm not wouldn't want to comment on that, but it's just. I think it's the way it's said and the implications that this person could just sort things out. And actually, again, we all know that a lot of the people who are diagnosed with personality disorders have some of the worst situations and suffering and lives that some of the people we see have. So I think it's very, very difficult. I think psychiatric diagnoses are difficult altogether. I mean, there's the kind of simple thing of, you can't just get a blood test which says you've got bipolar, for example. And I think I remember saying that, I don't know, it was to my psychiatrist or to someone else, that I really was not looking forward to the period when that would be available, because what if you got it and it said you didn't have it? What happens then? And, psychiatry is not, it's not clear cut. I mean, medicine generally, but I think mental illness is not.
Completely agree. And even coming back to the personality disorder, even the words personality disorder, I feel is an attack on someone's personality.
Yeah.
So even the terminology I find quite difficult to comprehend. And I agree with you. I think even you said when you were a junior, there was a lot of stigma, but I think even now there's still a lot of stigma. And
well, I find that interesting to hear you say that.
Really? Yeah. No, definitely. Yeah.
One question I had is, I guess to some degree, what we're talking about is the tension between, the subjective first-person phenomenological point of view of going through a difficult mental experience, and then trying to capture that objectively, as a professional, so you can communicate it to other professionals and try to, I suppose, give one's patients a description of their difficulties that can hopefully help them encapsulate them. But my question is, having had the breadth of experience you've had, is there something, ineffable about going through the experience from a first-person point of view that simply can't be captured by a third-person kind of descriptor?
Yes, I think that probably is true. I think the thing that I remember being struck quite early on in my psychiatric training, realizing that you couldn't understand what other people were going through, that it just wasn't possible. And therefore, there's that phrase of, I know how you feel, I know exactly what you're going through kind of thing. That is probably never a helpful thing to say. I think that what you can realize is that it's really difficult to understand. When you were talking about that, it made me think of the whole kind of mental state examination, and when you write down and the objective subjective bits and what that means, because I mean it's everyone's subjective view, both the doctor and the patient. It's no one's objective view. When I saw some of my notes once, which is not something I would particularly want to do again, I didn't see very many of them. The inaccuracies really annoyed me, over annoyed me actually. It was things like, I think I remember him saying my brother was older than me when he's younger than me, and it's irrelevant. It didn't, it doesn't matter, but it kind of does matter. It makes you almost think, what else didn't they hear, And I think there's the habit that people get of taking, a story from one consultation or admission to the next, and just kind of taking it as read, copying it and pasting it, that kind of thing. And it is something, I suppose, I always feel you have to ask those questions again. You have to try and get, a view yourself of this person. And I think you can never wholly put yourself in anyone's situation or in their feet, what it's like for them, but you can at least ask questions and try. And I think, I've certainly seen, case notes where things have been just repeated incorrect things over years. And I'm not trying to be a kind of snotty sort of consultant kind of view about that, because I think, we all do it, but it's, it feels like something that we really, we've got to try and listen to every individual patient. I'm also aware that, quite often we can't do much for people. I mean, that's just psychiatry. We do what we can and, prescribe medication when we can. We do, all the things we can. But sometimes, probably comes up for me more in chronic pain, actually, there is very little you can do. And actually what you can do is sometimes reducing medication, deprescribing or whatever one wants to call it. Sit with that patient and let them talk. And actually hear it and listen to it, both of those really. And they don't really think that you've got a magic pill. They don't think you're going to explain things particularly. But I think if people feel heard and they feel that you've been interested in some way, that makes a huge difference. It'll be great if we do have much better treatments, in the future. But there's always going to be. I mean, a lot of what we see in psychiatry is just about the awfulness of life, really, and so it's always going to be complex and tricky. And I think just acknowledging that to oneself and thinking, what we do is limited, but we can try and listen to people and take them seriously and hear them.
And I found when I am listening to people that drawing on my difficult mental experiences, the ones that I've had, really does help me to empathize, to the extent that that's possible. So if I can draw my sadness that I've experienced when a client is sad, or feelings of anxiety when my patient is anxious. Have you found similarly, given that you've had some of these experiences yourself, that has helped you to bridge that empathic gap?
I would say that I think people who experience any difficult emotion, which most of us do at some point or other, if you, I think that can help us get more close or better to listening. It doesn't mean that we can understand what that person is, but it makes us more open to it, and I think that's really important. I think for me, it was actually. I thought in my early days of training, when I'd, been a patient and then was an SHO, I think I did think, well, I've been a patient. I've got sort of better insight into what goes on here. And I'm not sure that I really did. I had a different insight, but I don't think it was necessarily better. And it was actually when I lost a baby quite sort of late on in pregnancy, which was a devastating experience, that I think I suddenly thought, gosh, I don't actually know what other people feel like when this happens to them. I don't know what it feels like when many difficult things, I don't know what other people feel like when they get depressed. But, I think maybe something of what you're saying, that some acquaintance with difficulties and suffering can make you, I think, better able to perhaps hear it, tolerate it, something. I'm not saying we want these things to happen to people, because obviously one doesn't, but most people will experience some difficulties. And I think if they in a sense, I suppose it's being able to use that in some way, and be able to, it's being able to process and use it in some way that can help you to do that. Because I think being a patient has a lot to do with how I am as a psychiatrist. I would I might not have even said that a few years ago, but I think it is, and there's no doubt really in my mind. But then, if none of this had happened and I'd managed to train as a psychiatrist from medical school and done well and everything, and it would have, I would have been a different psychiatrist, and I'd have probably had different life experiences. But it's obviously important to, I think, try and bring what you have while still making sure you're protecting yourself, because there is the big thing of you can't let yourself get too involved or too pulled into difficulties, or you won't help the person. And and there's also the big thing about, if you're seeing someone. I've had the occasional patient I've seen who's reminded me a lot of my situation, and I think at that point, because there's been maybe overlaps, it's maybe someone who was a mother, or that kind of thing. And I think I've always been a little bit wary in those circumstances, because at the end of the day, they're different than me. And if I get too pulled in, and it becomes about me, not about them. And I think, I find addictions extremely interesting, but I think there was a definite bit of me that thought, well, it may be better to not be doing general psychiatry, So, you get plenty of general psychiatry and addictions, but I think it's been better for me working in a slightly different subspecialty. Having said that, I've got many colleagues who work in addictions who've experienced addiction, and I think I find that a very important part of what they have.
I was going to ask, actually, Rebecca, how did you end up doing addictions? Was it for that reason, or did you end up in it by accident and you were pleased?
my higher training was in general adult psychiatry, and I think I did quite a lot of CBT, which I enjoyed. But then I thought, well, I know nothing about drugs and alcohol. I need to get some experience in this. And then, so I went off and got my next attachment in drugs and alcohol. And I just really, really liked it from the beginning. It's hard to explain. It just felt like the right thing. There was also, let's say, the shallow bit, because there was a little bit of me that also thought, if this is slightly more controlled than general adults, I can probably work part-time. And, it was easier than doing a general adult job and doing that. It was also, I was particularly lucky in that as consultants in substance misuse in the particular place I work, we don't do any on-call. So that was great. But so that's the some of the reasons. But I love working in addictions, and it also pulled me into wouldn't pull me in exactly, but I ended up working in chronic pain because I did a pain and dependency clinic. It must be 10 years ago now that I started that, and then I've carried on working there, and that's been another fascinating area, which is very overlaps with both, addictions and general psychiatry.
I was wondering, because I haven't done a job in addictions, what exactly does it entail?
Well, when I started, it was very much, it was sort of two halves. It was the drugs bit and the alcohol bit. And for us, and in Edinburgh, and that was, I can't remember, it's probably nearly 20 years ago now, but it was after the whole kind of HIV stuff and everything in Edinburgh. And there was a lot of substitute prescribing, mainly of methadone for people who were opioid dependent. And that was probably a big bit of it. So it was harm reduction and then treating people's other mental health, that kind of thing. And alcohol was very much abstinence based. So it's detoxing people and trying to work with them to stay off the alcohol. That's a very, very rough description of what it is. They're now joined together, so we have drug and alcohol services, and I think it's been largely responsive to what's needed. I would say alcohol and opioids are our bread and butter, benzodiazepines, but when the novel psychoactive substances turned up, we had to deal with them. And there's things like the gabapentinoids have been quite on our radar recently. It's really, as I say, what's going on as to what you do. But there's a lot of prescribing, and I actually work in the inpatient unit, so a lot of what I'm doing is alcohol detox or opioid conversions.
And on that topic as well, I was wondering, what is your opinion on the use of psychotropics in psychiatry, like using ketamine for depression and magic mushrooms and things like that?
I think I would have to say I just don't know, really. Having said that, I would say, ketamine's obviously had a lot of work done on it. And I think I would welcome anything that is new that we could be using, because I think so many people get very, very stuck in these disorders. There's the issue of ECT, which is the only rapid treatment we have at the moment. And I think it would be great if there was something which was an alternative to that. I have read a bit about the sort of more psychotropics with psychotherapy, that kind of thing, more for PTSD, addictions, depression. I think at the moment, I'm not sure. I'm trying to find out more about it. A colleague who's very interested, but it's not something I've worked in at all.
I was also wondering how COVID has affected your patients.
Well, yes. That's been quite tricky in that when COVID hit, I think it's affected everyone, obviously, across the board. But in our psychiatric hospital, my detox ward was turned to a COVID ward. We have a lot of patients, but we took some of the largely elderly patients, from other wards to keep them safer, and did that for, it was probably a month or so. I think, that was fine. I think the big issue was that it meant that we weren't detoxing people. We weren't providing the usual treatment for our patients. And I think we were all worried and upset about that, and did quite a lot of work to get that back on the road. And it is going well now. I think in Scotland there's quite a lot of money being put into drugs and alcohol services, so it's looking a lot more positive than it was then. It was a difficult time.
Mm-hmm. And I'm sure I know the answer to this because I've read your blogs, but have you ever looked at any one of your patients and thought you've brought this on yourself, or have you ever felt like you've lacked sympathy because of the nature of psychiatry that you work in?
In addictions, do you mean particularly?
Yeah.
No, I don't think I do think that with patients. I think one of the difficulties can come, you get a bit of a sort of cognitive dissonance thing happening sometimes when you speak to families and you speak to patients, and sometimes you realize what's happened to other people perhaps because of this addiction. And it doesn't make you, I mean, I suppose I feel the patient is my patient, and there are almost always reasons and difficulties, genetics, whatever, behind what happened to them. But sometimes it can feel, when they've done terrible things, and I don't think I personally feel you've brought that on yourself, but it can leave you thinking, feeling sad about the whole situation is maybe more the kind of way I would feel. It is difficult. I mean, and it can be frustrating because I suppose you kind of think, there's just the natural way of thinking, which people do, why can't you just not do that? But that's the whole point. I mean, that is the disorder. So it's I think particularly having been there so long, I mean, I think in the same way that you can get a little annoyed with many people in many walks of life many times, some days you can get a bit more kind of, oh gosh, I wish things would be better or they could change that. But, I mean, they're in this situation because they have this thing that's happened to them. And, it's usually pretty dreadful for them as well.
You mentioned ECT a couple of times, and I think you're in a very unique position that you've been a patient of ECT and you're also a consultant psychiatrist. Would you mind firstly explaining a little bit about what ECT is and then telling me what ECT was like for you?
Well, ECT basically is a treatment where someone, and it's usually given to people who are very depressed or even catatonic, occasionally to people with acute, sort of other problems, but largely very severe acute depression where there's a risk of self-harm or suicide or neglect such that they wouldn't drink or eat. And essentially what happens is that they get a short general anaesthetic from an anaesthetist and a current passed across their temples, essentially, that induces a brief fit seizure. They're given a muscle relaxant, so you can't really see it, but they have this seizure lasting for a short time, and then kind of come round. I haven't myself given ECT for many, many years. I mean, like everyone, I had to do that when I was a trainee, and I did find that a wee bit tricky. I mean, it wasn't something I would have chosen to have done, but we had to do it. And I did see people getting better, so that was a kind of positive thing. But I'm actually very glad I don't have to do it. And I suppose I think of ECT more as a patient, even though I'm a doctor. And I counted up how many ECT treatments I've had, that individual treatments over the year. My psychiatrist said it was probably about 70. I suppose it's quite a lot, but obviously all in briefer courses. And I knew it was controversial, but I hadn't realised probably quite how controversial it was until the last few years. And I've read various accounts, and I do look on Twitter and stuff. And I know there's some people who are very, very upset by it, and very upset and angry, and feel that it's something that can cause damage, and that that it shouldn't be being given, or that things should be changed. My experience has been that it's worked very quickly. I mean, my initial few years when I said I wasn't very compliant with my medication afterwards is probably why I had quite a lot then. But since then, it's been sort of discreet. I mean, I last had it in 2018, so that's nearly 3 years ago. And I was a lot better after it. So it does give a very quick response. I think the difficulty is the memory effects, and I think I was probably originally told some people got problems with their memory, some didn't, and it would all come back. And I think that was probably a slightly naive way of presenting it, that I think most people get memory problems. Certainly everyone I've spoken to has described that.
That's not something that I think I've been taught, to be honest. I think they say some people get memory problems, but
I think, I mean, I'm not speaking as a doctor here. I'm speaking as a patient about, other patients I've spoken to. But I think people do get memory problems, certainly around the time, and then, sort of while during the course. I can't remember some of the time before that. But I think I didn't quite realise it when I was first in, because I was an inpatient, and to be honest, nothing happens on an inpatient ward, so you don't really know what you've forgotten. But I've had it as outpatient since then, and I've been much more aware of it. I think I do think, I mean, I don't feel that I have brain damage. I'd like to really make that clear, that I don't think I'm cognitively impaired. But I think the memory problems around the time of treatment and afterwards are quite difficult and quite distressing, and you lose confidence in yourself. And although it ends, I think, remember someone describing it, it's like a sieve. You've got kind of holes in bits looking back. I don't consider I have any problem making memories. I don't have any issues with that. But I do, looking back, most of the times around having ECT are very, very, very blurred, and I can't remember a lot of things. Sometimes, people will say things in the family from things that happened then, and I don't know what you're talking about. So I think that it probably does cause memory problems for many people. I think the difficulty with the worries people have, I mean, there's the bad press, there's the One Flew Over the Cuckoo's Nest, all the kind of television and film programs. They were probably made at a time when ECT was a little bit less comfortable, when it maybe didn't use anesthetics as much, that kind of thing. But it's a very easy thing to go through now. There's no discomfort or anything. I think the problem, and I've thought quite a lot about this, with the issue of what people, why it is that some people say they have brain damage afterwards. And I think first thing I would say is, every medical treatment has risks. I don't know what happened in their treatments, and things can go wrong with anesthetics. If things can go wrong with your heart during a heart operation, things can probably go wrong with your brain. So I'm just speaking in very, very kind of loose terms there. I think the other thing is, though, that a lot of people are very unwell and maybe have been for a while, and perhaps things haven't got as better as they hoped, and sometimes maybe that is part of the problem. But in any case, I think there should be care and support for people in that situation, to try and enable them to work out what has happened if something has gone wrong, cognitive testing or whatever, and support to manage it. But it's a difficult thing. I mean, if someone, and obviously I've been asked the question whether I would have ECT again, I think my answer would be, I very much hope not. But yes, if I got very depressed, I would have it again, because it has worked, and it does work, and it works much more quickly than some other things do. But it's a very difficult subject, and you can feel a lot of sympathy with people who've not had the experience that I've had.
That kind of brings me on to another question I wanted to ask you about, because when sometimes we give ECT to patients that don't have capacity in a life-saving situation, and the doctor has the power to make that decision, one thing that I have found I struggled with when I've started training as a psychiatrist mainly, but also when I was a junior doctor in my foundation training, is the amount of power that we have as doctors. When someone's admitted to an inpatient ward, we control when they eat, when they get fresh air, pretty much everything they do. And also, for example, we have community meetings where patients will sit round and a doctor or a therapist, whatever they may be, may stand up and kind of lead a discussion that feels quite like a school-like manner. And I know you've written a blog about the power of being a doctor. With your experience as being a patient as a doctor, what's your opinion on that?
I think as a doctor in psychiatry, we have we have a certain amount of power that we have to use properly and correctly, and we have to consider what we're doing. But I think the fact that we have the Mental Health Act, I should go back to my decision to work in addictions. Actually, I rarely use the Mental Health Act, and that certainly, if not the thing that made me go into that, is something that I'm very grateful for. And by that, I don't mean that I disagree with the Mental Health Act, not at all. But I think having been a patient and having been on the other side of the act on at least one occasion, it's not something I particularly want to do. And I know that's a bit of a cop-out, that in a sense, I should be saying, well, I understand this, I'd be quite happy, but I'm not really. I do find the situation of, taking away people's liberty, like you will have done. I've seen people who are extremely ill, and I don't have any doubt that the Mental Health Act can be appropriate. But personally, I struggle with that. I think it's a very difficult thing to do. And I think, it's probably, the cases where someone is very acutely ill. I mean, the times when I have to use it are more when people are in DTs or something, when it's very, very obvious they're unwell. There's not a question. And it's not for long either. But the idea of people who are ill but less acutely ill being subject to the Mental Health Act for any length of time is quite difficult to think about. And I think just because we have that in psychiatry, it does make things a bit different than doctors in other specialties. If you decide you don't want go back to the old heart operation, someone's just going to say, well, they didn't want to have it. Whereas, you don't want to take your depot, that might not be the case. And I don't know what to think about it. It's interesting because we can't detain people for being alcoholics. Obviously the results of that we can. I mean, if someone's in, as I say, DTs, or they get cognitive impairment, drug-induced psychosis, yes, you can, but you can't just detain them because they're drinking a bottle of whiskey a day. Sometimes I find myself thinking, if you went back to first principles, why not? But I'm not saying we should do that either. But it's more a case of, why do we do what we do? And, we have got a lot of power over people. And I think the kind of treatments that we have, I suppose that, there's the whole thing about, if we detain someone, we should be providing them with appropriate, treatment and etc. But I think the issue is that a lot of our treatments are not particularly pleasant for people. A lot of the medications we use are not ones that many of us would comply with necessarily if we didn't think we needed to have them.
Definitely. And I've read that you've had to take lithium in the past. Do you mind talking about the side effects that lithium has had on you?
Well, lithium, you see, is great because actually I don't have any side effects with lithium, which is probably the reason why I've been more compliant with lithium than anything else. I've taken lots of antidepressants. They all have side effects. They're all unpleasant. And I've taken antipsychotics, which are gruesome. I struggled quite a bit with, and I know that I had less side effects than a lot of people do, but, I gained a lot of weight and just generally felt out of it really a lot of the time with that. And but lithium is probably the one thing, I know a lot of people don't like taking it, but the one thing that I found is side effectless. And obviously you have to get your blood tests and things. I think I'm on probably a relatively low dose. It's really not a bad medication to take. I think it was probably worse in days gone by when people were on probably higher doses more. I think a lot of people have lower levels these days.
Are there any non-medication treatments, even things which are less conventional that you just do in your personal life, which you found have helped you?
Well, a few years ago, I did do I'm not a very sporty person, but I did Couch to 5K. And I have to say that did make me feel better. And I'm not doing it anymore. And I'm thinking about whether I should do it again. But I'm not someone who tends to, I'm probably a fairly average person. I don't do a lot of sport. I don't, do a lot of things there, but I do try and get out and walk. I play the violin, and for me, that's a really important thing. And actually, over the last few years, when I've been writing about various things, I think it's helped me to work out what I think about a lot of things and make it a bit clearer. And it also just, I don't know whether these things are good for you. I was thinking recently about the whole difference between mental illness and mental health, because we always talk about mental health. And I suppose I would do those things to try and keep my mental health. But I think probably I need the lithium for my mental illness. I know that's dividing it into two. And things are never that straightforward. And, I'm open to people saying, well, maybe it's not. But maybe it's not a mental illness. But I think for me to try and work it out for myself, that's been a better way to do it. But I also work part-time. I reduced my hours after my last episode of illness. And it's difficult because I'm always thinking, could do a bit more, could do this, could do that. And I do end up doing more. But I think it's probably a good thing. I think the work, this is not very connected, but I look at the work of being a psychiatrist now, and we certainly see a lot more people going into it who are training less than full time and want to work less than full time in future. And you also think, gosh, if they're going to make you work till you're 67 or 70, work less than full time. You've got to look after yourself. And I think that's same for everyone. I think perhaps it's more so, if you have got a mental illness, but it's not necessarily, anyone can run into trouble. But I think everyone should be careful, because I think medicine is overwhelming at times.
I was going to ask, do you think that people with bipolar were always going to get bipolar, or do you think the life events the genetics are a catalyst and the life events trigger a bipolar illness?
Probably, I think, is what I would say to that. I don't think anyone could say that you would definitely get it in all circumstances. But I've got a family history of mood disorders on one side and possibly the other as well. And, I assume that makes me more at risk of a mood disorder. But people obviously do get it who've no family history at all. I think it has to be probably a combination. There may be people who have a very strong genetic component who are going to get it with less psychosocial sort of happenings kind of thing. But, I think it's difficult to know, and it's difficult to quite know it would be interesting to be more aware of the kind of things that make you more likely to get it. If you've got a predisposition, like, I might say, for instance, for my daughters who are probably going to be genetically more likely to get mental illnesses than others, what should they think about? But it's very difficult actually, because I can't say to them that there's this one thing that I did that was really stupid. It's actually maybe it was having them, because there's the I think obviously there's the kind of whole giving birth thing and perinatal aspect to it, but obviously you can't say that. In a sense, I know some people with bipolar make the decision not to have children, and I would absolutely understand why they would do that. And I do remember, and I still think, looking back, why did I have another one? After what I'd experienced, and I think the answer is a sort of the kind of biological, I wanted one. And, it's not particularly impressive saying that. Maybe I would have been better not to, but obviously, it wasn't like that. I think that's a very difficult decision for, and it gets you into very difficult territories, starting to think about, whether you should have kids. Should you have kids with other medical conditions? It's going to be an issue when we start all getting our DNA checked.
Maybe ignorance is bliss.
Well, maybe it is. It's I think it's it goes with my comment earlier on, I think, about saying that I'm not sure I would have the blood test that would give me a yes/no answer. But just because, yes would be quite bad, but actually no might be worse. That would kind of prove the old personality disorder. or something, it's, but I think it would be very difficult, and that, there would be people who were, what's wrong with me then?
Taking you back, just slightly back to mental and behavioural disorders secondary to alcohol and illicit substances. I know you're a consultant in addictions, and I have found that a lot of people say that alcoholism is not a mental health condition, and I've had patients come in to A&E and they've been struggling with their mental health, feeling suicidal on a background of being an alcoholic. And I've seen people document saying no acute mental health illness, despite the fact that this patient may be suicidal secondary to consuming alcohol. I wanted to know what your opinion on that was.
Well, I think that kind of thing makes me a bit cross, really, because the problem is the resources. That's what it comes down to. People are put in the position of having to say that because they've got nowhere to admit people to. They haven't got the resources to offer these people. But essentially, and this is something I say to my patients, when they come in for a detox, many of them are depressed, and in the circumstances, and it is the case, let's get you detoxed and see what your mood's like. And many of them pick up and some of them don't. And you can never say chicken or egg, really, which came first, because people don't remember these things clearly. If someone says, I was definitely depressed beforehand, you can't be sure. You still need to get them off the alcohol to treat them. I think the problem is it's the way we don't always work well together in addictions and general services, and that kind of situation is exactly the person coming into A&E. No one's going to want to do anything for them in that situation. I don't know what, I think if we could put we had some sort of service that we could be putting in to provide, community or even inpatient detox for such people, and then follow up to look at their moods, that would be good. Because, obviously putting them on antidepressants at that point isn't good either. But it's, I think it's a reflection, I think, more of what we have to offer people. And I think it gets very difficult because I think it's actually one where if you take yourself out of being a psychiatrist and think, I'm going to be general public, them seeing us say that kind of thing to people, going, how can you do that? Because often in televised things as well, people are drunk and suicidal, and it all gets taken seriously there, whereas it doesn't always in psychiatry or in A&E. And I think it's quite. I think it would be good to do more about that. I think it's a real problem. And I don't think, going back to your original point about mental illness with that, obviously there's people who drink. There's, people who just drink socially. There's people who drink harmfully, that it's causing mental or physical problems. And there's people who are dependent. And, again, it's difficult to make a cutoff. I personally do believe, from what I've seen over the years, that there's a definite genetic predisposition to this, and for some people, when they drink, the whole kind of sort of pleasure sort of response, the whole kind of behavioural thing is different. Some people have a drink and they don't want to drink anymore. And I always remember someone saying to me who'd had an alcohol problem, and who was now abstinent, that they just could never get enough, and that's different. So some people wouldn't experience that at all. So there are definitely different things going on, and I think for some people that ends in alcohol dependence. I think if you start thinking as to whether that's kind of primary illness, I suppose you could say some of the it gets very complex. You start thinking of things around smoking or gambling or anything that can lead to problems, and it almost feels a bit like just nomenclature. This person is alcohol dependent. They may not have got cirrhosis yet. They may not have got alcohol-related brain damage yet, but they cannot stop drinking. And when I say cannot, they maybe could if they were locked in a room, but it is much harder for them. And I think, again, it's that, from the point of view of thinking of oneself as someone who doesn't have that feeling, that it's really important to be able to recognise that it is different for some people.
It seems quite unfair that some people are more predisposed to that.
But I think that the whole point is understanding that and accepting that, because people will be looking at someone and say, why can't they just stop? They can see the harm this is doing. Why can't they just stop? Some people can't stop, And I mean, that is the illness, you might say, in some ways. It's a very difficult thing.
Yeah, I did a podcast recently with Robert Ploman, a geneticist, and we were talking about the heritability of various things, including something as mundane as body weight,
Yeah.
And body weight apparently is about 70% heritable.
Yes.
In the West, at least. And I think alcohol is 40%. Alcoholism is about 40% heritable. So genetic differences account for 40% of the difference, which is pretty significant.
I think it's very significant. And then I guess you add in deprivation, and you have a lot of people who are really struggling with that and having the results of it. But it's a very rewarding thing when people do well, but it can be very chronic, and it's hard to. We don't have any magic wands. It's ongoing support, really.
Yeah, I bet it is really rewarding.
And not ignoring their mental and physical health. I mean, I think that's one thing where I'm glad I did GP training, albeit quite a few years ago. Was I think the physical health stuff interests me a lot, and I think I'm more comfortable with that than perhaps some psychiatrists, just having worked in this. And I think again, their mental health problems do need to be addressed. They may not be as much serious as the people who are inpatients for primary mental health problems like schizophrenia, but if you don't treat their depression, they will almost certainly drink again.
It's interesting that you mentioned physical health, because you wrote a blog on whether psychiatrists are doctors.
Yes.
Which I find very interesting, because there is definitely stigma amongst doctors against psychiatrists. And I think people think that fellow doctors might say psychiatry is easy. We don't do much. We've got really chilled days. And then gradually we don't become real doctors. What would you say about that?
I would say try and work with some of these people. I mean, one of the things that I do is, I work in this pain clinic and I work with consultant anaesthetists. And I think we've both probably got much better understanding of what we do from working together. I mean, there's sometimes I'm there and I think, oh God, it'd be so good if I could stick needles in people's backs and do clever things, and it would be great. But then, I think it's very easy as a psychiatrist to think you don't have any skills, but actually, I think it's almost trying to remember what it was like when you hadn't done psychiatry and what people will say. Because although people can be critical of psychiatrists, they're very quick to call them in if they've got what's perceived as a psychiatric problem.
Yes.
And I think actually I would encourage, just taking the time to speak to anyone whenever that happens, or, any situation, because I think once they realise, that we will deal with difficult situations, we'll talk to people in difficult situations, we'll talk to their relatives, we'll do these things, and that we've kind of seen similar things before, then they become, I think, a little bit more, like we respect them, they respect us kind of thing. I think it's slightly difficult in a way, the situation of having different hospitals, like we have our psychiatric hospital and the acute hospital. That can become difficult. But, again, for me, I'm on fairly good terms with the hepatologists, which is really helpful.
Yeah, that must be very useful.
I think, and they are very, it's very mutual. So, I can get in touch with any of them and they can with me. So I think I would say it's fear as well. They're obviously frightened of our greater powers, but I think it is that they, maybe just don't know what we do. And I suppose we don't do a training where we learn some sort of, thing like suturing or anything. But I think we do learn a lot of skills. I think it's got a bit better, was my impression over the years, but maybe that's just from where I'm sitting. Maybe they're nice to me because I'm a consultant.
Applications have definitely gone up significantly, and filling places is really good now. So hopefully it has got better.
Yes,
I was just going to say as well, I was giving teaching on alcohol, and I was actually thinking to myself, I don't think there's any area of medicine where alcohol wouldn't be involved, even in radiology, even in pathology. I think alcohol, maybe more so than psychiatry in general, I think I can't think of a speciality where it wouldn't affect it.
Well, it absolutely fits into everything, I would say.
Yeah.
I think the other thing, I mean, we have a sort of alcohol awareness day for medical students, and we do various teaching for kind of older medical students. And one of the important things is that people are likely to come into contact with colleagues who have drinking problems or drug problems. But alcohol use is common amongst doctors, and I think for one of the important things is for people to recognise that, either in themselves, which may be hard, but also in other people, even potentially their seniors, because it's very difficult. You smell someone a bit of alcohol, you think, oh, well, it must be aftershave. There's that kind of quick to, sort of try and explain it away. It's very difficult to do. And I think that's something which is really important to try and talk to medical students about, to sort of, I guess it's empowering them to help each other and others. But I think it's probably one of the things that can come up that, I'm involved in GMC work as well, which I find very rewarding and interesting. And doctors can do really, really well with addiction treatment, but they can obviously do really badly if they don't have help. And there's obviously the potential for a career to go down the plug hole, that kind of thing. So
and risk to patient as well.
Risk to patient, absolutely. So you really want to try and engage them if you can. But I think again, talking earlier about the difficulty of admitting to having any mental illness. I mean, I know people will talk about, I had 7 pints or whatever at the weekend, that kind of thing. But actually people admitting, I think I've got an alcohol problem, I think it's possibly even harder. It's a really difficult thing to admit. And the kind of alcohol and sort of mental illness will get very entwined as well. I mean, I think it's not unusual for someone to be presenting with, I think, as we kind of alluded earlier, with low mood, sometimes for years. And then it turns out to be that they're drinking quite a lot of alcohol, and that's maybe more the problem.
And I agree. I think the culture of drinking at university within med school is very much a culture. I don't know if it's changed. I trained not that long ago, but
I think it's still, I think maybe it's less than it perhaps, I think I tend to assume it's better than when I was at medical school, but maybe not. I think from speaking to students and junior doctors, I think it's still a time when people drink a lot. A lot of them then, drink less as they go into sort of foundation and training. But there'll always be a few who carry on, and it probably becomes less open when you're not one of many.
Yeah.
But I think it's a really important thing to try and support people with and to raise awareness of. So, I mean, I would encourage you to include that in any teaching to students or junior doctors, actually, that it's something to think about.
I completely agree. On that note, I'm going to steal one of Alex's questions that he asked at the end, which is, do you have any advice for me as a trainee very early on in my psych career? What advice would you give me?
I'm trying to think of what I would advise. I think immediately my reaction is to sort of compare it with my own training. And I would say, don't be too hard on yourself. It's my first thing. Try and do other things. Keep your life alive, apart from just medicine and psychiatry. But people are usually doing these things because they're really interested. So again, I would say, do a lot with the bits you're interested in. I think that's really important. Get involved with things that you really want to do. Get your exams over quickly, but they just kind of get in the way in many ways. And take opportunities that you can. When you're younger and when you're older, and when you're even older. So I think it's thinking of what you can do at different times. But I think the main thing is doing the things you're interested in, absolutely going for it, but looking after yourself. I think that's what I'd say to most people. And don't get too pulled into e-portfolio there, but that's probably the wrong thing to say. Obviously, keep up with all your e-portfolio work. Yeah, do take care of yourself. I mean, I think that's probably the most important thing. And and remember what it's like being a trainee when you're not a trainee any longer. But I think seize opportunities is probably the thing that, I look back and in some ways I worked really hard and it stopped me seizing other opportunities maybe at the time, that if what happened hadn't happened, I might have done. On the other hand, there've been some very good things have come from that. So, it's accepting what life throws at you, but trying to make the best of it without beating yourself with a stick.
Thank you so much, Rebecca. I've loved talking to you, and I also want to say thank you for publicising your diagnosis. I feel like it's not an easy thing to talk about, but I think you really will have helped a lot of people, patients, fellow doctors, fellow psychiatrists, to understand so much more than we could. And if it wasn't for people like you, I don't think that we'd be able to move forward and understand conditions.
I think it's difficult. I suppose there's one thing I would just finally say was that obviously this has been around for me for many years, and I did write a few things early on, but I didn't do much with them. And I remember one time showing a piece I'd written to a consultant who I can't remember whether I worked for or whatever, and he said, "Well, it's all very good, but wait till you're old and grey. Don't it'll get you into bother if you publish this now." And I kind of did take that advice. And looking back, I'm not unhappy about it, although I don't think you should have said that. But I think the thing that for me was important was, like doing more and saying more, and in a sense, campaigning more now is possible for me because I'm, at this point in my career, sort of later on, and I have more time. But most of all as well, because my children are old enough and they know what I'm saying and doing, whereas I couldn't really have done it before. And I think that's, quite important as well. And I think with you can't just go barging into things. I think with timing, it was kind of the right time for me to be able to say more. It didn't feel difficult. I mean, people have said to me, "Oh, it's courageous speaking out." Anyone who knew me knew about it. So there's not really been any issue with that for me. And I just want to try and say or write things that can be helpful to anyone, really.
And on that note as well, I just want to say that your blog is amazing. And when I read it, you make me feel so relaxed. So anyone who's listening, please go and listen to it. Is it doctor-and-patient.com?
Is that right? I can't remember. It's terrible. But yes, it's been. I thought when I started doing that blog, I'd write a couple of posts and lose interest, and it's actually been a really, really positive thing for me doing it. And sometimes I think I'm putting far too much on it, but then on the other hand, no one has to read it. It's something I would recommend to anyone to do. It's just been really.
Thank you so much. Alex, do you have any more questions?
No, just to say thanks very much for coming on, Rebecca. You're welcome back anytime.
No worries. Enjoy your evenings.
Thank you.
You are listening to the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.